Today's podcast, we're talking all about the pelvic floor health, and some real practical exercises, things that you can do to help improve your health down there. Today's special guest is Kim Vopni. She's known as the Vagina Coach. Just, just straight on the Vagina Coach. She's a fitness professional and menopause support practitioner, and she's known as the Vagina Coach. She's a sought-after speaker, women's health educator, and the author of 3 different books. Now she's working primarily with women in perimenopause and menopause, which is how I have come to have her on the podcast today. She's got her own podcast as well called Between Two Lips. I don't know why all of this makes me laugh. It's the nervous laughter, folks. Anyway, I think it's great to talk about these things because oftentimes we won't, right? And we need to have these conversations because chances are if you're experiencing something that is causing you grief, someone else is as well. So let's dive into this topic about pelvic floor health and welcome Kim to the podcast. A few weeks ago, Kim and I met at a conference, and then I started following you on social media. And one of the things that started to come into my feed was the buff method. And with it, some interesting exercises that I had not seen before. You were using a ball in some of them. Maybe you've seen this in your feed, folks. I don't know. But sitting on some of them, like literally exercises I've never seen before, but thought, well, who doesn't want a buff muff? So, so I've been following you ever since. And I wanted to have you on the podcast because this is something in midlife, growing up maybe in the 70s, 80s, we didn't necessarily talk a lot about pelvic floor health, how to optimize that. Like it just wasn't in our conversation. It is nowadays, like our daughters probably have more of an inkling about how to care for that than we did. Mm-hmm. Still, I'm sure there's a lot of far ways to go in terms of education. This is something that I think a lot of us will struggle with silently, right? Alone, and not really ask the questions because just as I had a little bit of laughter at the beginning and embarrassment, it can be an embarrassing topic to talk about. So I would love to know, first off, how did you come to be known as the Vagina Coach? Because that's Kim's title.
That's always the first question. They're like, well, this is a little different. Yeah, I always say, I didn't grow up with these aspirations that I'm going to be the vagina coach or preach public health. I didn't even know the term. I didn't even know the term. So really though, when I was younger, I saw a childbirth video as part of our sex education at school, and that planted a really deep seed of fear, but also curiosity. So I went home and I was looking at my mom differently and all the women in my life, and I thought, well, they did it and they survived. But still, I was like, but I don't really want to do that. And when I did ask my mom questions about her births, she was sharing that she had something called an episiotomy, which is where they cut into the tissues within the pelvic floor. And thankfully, that's not done. It was done routinely back in when she was giving birth, but not anymore. It still happens for an emergency. But anyway, I heard that and I thought, okay, I'm definitely not interested in this. And then I also was witnessing my mom stopping exercise. She used to be a runner. She stopped running because she was leaking urine. She had chronic back pain. She had a hysterectomy, she had incontinence surgery, and all of it kind of was tied back to pregnancy and childbirth. And I thought, it was just all these little ticks like, nope, not interested, not interested. So I grew up saying, I'm never having children. Yeah. And then, I remember having a sticker. Remember, we always had sticker albums, right? And I had a sticker album when I also would take little clippings out of magazines. And one of them says, I do not want a baby. And that was very prominent in my sticker album. So it was like, I was adamant that no way I was going to do this. Anyway, you grow up. I met my husband. That's obviously a topic of conversation. And I was open. I said, I'm not really totally sure if I do or not. But anyway, we were we were married at this point, and his brother and sister-in-law were going to have a baby, and they allowed us to come and witness the birth. And that was the first time that I had ever seen anything different than what you see in the media. She was with midwives. She was still in a hospital, but in a side-lying birth position. I thought, how the heck do you give birth in this position? And anyway, so it was a very pivotal point, and it was also very empowering. And I remember asking her, is everything falling out of you the next day? And she said, no, it feels a little sore, but I didn't have any tearing. I did something called perineal massage, which I'd never heard of. So I started looking into that, made the decision not long after that, I want to do this. I want to start a family. Next year, I'm pregnant and I'm asking my midwives, what can I do? I've heard of perineal massage. What else can I do? And she tells me about this biofeedback device called the Epino, and Epino stands for no episiotomy.
Mm.
And so I look into this and I research it. I purchase one, I use it, I don't have any tearing. And then I say, well, why is not the whole world using one of these devices? And I contacted the company, said, could I be a distributor? And I didn't think it was going to be a business. I thought I'll just sell it on the side to my friends and I'll have a little extra pocket money. So that's how it started, very much of a side thing. A few years later, I was laid off from my job. So I had worked in fitness as a personal trainer for many years. Then I went into human resources. So I was working in a desk job. Lost my job in 2009 when the financial world sort of fell apart. And then I thought, okay, well, I guess I'll see what I can do with this. And I created a website and I started to sell this and try to get it out into the world more actively. And that was still sort of a side thing for a couple of years. And then, yeah. And now here we are 21 years later. So that's how it started. Originally, as I said, I was a personal trainer. I focused very much in pre-postnatal, and I ended up starting a second business with two other women called Bellies Inc. And we wanted to optimize the postpartum recovery. So my work was I was called the fitness doula, and I was helping women prepare. So I wrote a book and created a program called Prepare to Push. Then we started Bellies Inc. And then I started to go through my own perimenopause journey. And then I recognized that there's a whole other population. And this is really not just a do your Kegels in pregnancy conversation. It's really through our whole life. And when I was going through that phase and now starting to work with that population, fitness doula didn't resonate so much. And I was speaking to a group of women entrepreneurs at a conference in Toronto. My talk was how optimizing your pelvic health can make you a better mompreneur. So it was a group of women entrepreneurs who were moms. And I went up on stage. All of the other speakers had been some sort of a business coach, like marketing or strategy or what have you. And so I joked and I said, now you have a vagina coach for your business. And anyway, that's how that started. That was about 8 or 9 years ago now. And that was kind of the light bulb moment. I said, this is what I need to do. I need to step into this word that nobody likes to say. Everybody hushes it. It's uncomfortable. And that's contributing to part of the reason why there was so much silent suffering with regards to pelvic health.
Well, one of my favorite quotes is by JFK, and he says, "The time to fix the roof is when the sun is shining." And it sounds like that's exactly what you're bringing to this population, is that let's do some prevention. Let's do some preventative techniques. A lot of us get to the place where we're in trouble, right? If it's with our pelvic health, with our health overall. And so we'll often seek out a professional when like things are at their dire straits.
Yeah.
And what would be nice is if we didn't need to wait till the nth degree to seek help, but if we did some things beforehand. And that's where I like your programming, because it's like you've got things that you can do today to help prevent, drastic things from happening. So let's start to work on these things. What sorts of things are you seeing then? So you talked about birth and, sort of making sure the body's ready to push and ready to give birth. So what sorts of things are you seeing in terms of issues in the perimenopause and the menopause woman?
Mm-hmm. Yeah, women wait on average 6.5 to 7 years before they actually seek help. So they are suffering for a long time usually, and often they're just thinking that it's normal. They may even have been dismissed by a care provider. They see advertisements that say that late bladder leakage is just part of being a woman, and so they're just kind of accepting it. And it's something that's very, very treatable. And as you just said, prevention is really where we should be. However, most people are more motivated to overcome a problem they have than they are to prevent it from happening in the first place.
Totally.
And then when we get to perimenopause, menopause, many people will have been dealing with little like, oh, I just only when I jump on a trampoline, or I've had
Jumping
this kind of
jacks.
pressure in my pelvis. I didn't really know what was there, or sex was starting to hurt, but it was fine. Just use a little more lube. So they're kind of making excuses and putting up with things, and they're dealing with all of the other stuff that's happening in life. It's a busy time of our lives. Then as we start to get closer and closer to our menopause, when we're really into that low estrogen state now, that's where either things are going to show up for the first time, or all of those little naggy things are really going to start to scream at you. Stress urinary incontinence is where you laugh, cough, sneeze, jump, some sort of exertion and you have a little bit of urine leaking out. And that's the one that the pad companies are marketing to us, saying, just put one of these on. It's normal,
Right.
it's natural, and then jump on the back of a motorcycle with a handsome man and everything's fine. So that's stress urinary incontinence. Then we have urgency, and this is where people say, I'm fine until I get home and I put the key in the door, or if I hear the sound of running water, or if I'm particularly stressed out, or if I wake up at night and I have a hot flash. This is like a sympathetic nervous response. It can be tight muscles. It can be from a lot of different things, but it's like an overwhelming urge to have to get to the bathroom now. And it comes out of nowhere, and people can lose a little bit of urine on the way, or they may have a complete release of the bladder.
Mm.
So that's urgency or urgent continence. Then we can have both of those together, which is mixed. You can have anal incontinence where gas or stool leak out. A lot of people will say, oh, I have a small bladder, or I have an overactive bladder. There
Right.
is a medical diagnosis of overactive bladder, and there is a series of tests that somebody would go through. However, what I see in my population of in my community is women will finally go seek help. They go to their family doctor. In that 7-minute visit, they're explaining some symptoms, and they are given overactive bladder medication without a true root cause investigation. Do you really have an overactive bladder that requires medication? Or is it low estrogen? Is it constipation? Is it dehydration? Is it tight muscles? Is it training because you have trained your bladder to go more frequently? And so there's all these other little things that just aren't captured in that 7 to 10 minute visit that we have with a medical doctor. And so they then get put on medication, and they might notice a little bit of help for a period of time, but then they're like, but now it's not working anymore. And it's sort of, it's like, well, because that's not really what you need. You don't truly have an overactive bladder. You have lifestyle, you have things that have contributed, and it's never just one thing, it's multifaceted. And we can now just unravel those and get you back to not having those urges and not being controlled by your bladder. So that's the incontinence piece.
Mhm.
The other piece that's important to talk about that actually statistically is more common than incontinence is pelvic organ prolapse. And this is where the bladder, the uterus, the rectum can start to bulge into or descend into the vagina. And early stage prolapse can often be asymptomatic. 50% of women who've given birth have some degree of prolapse. Because it's asymptomatic at an early stage, a lot of people have no idea. And when we see somebody maybe for an annual check and we have a pap, when the speculum goes in and it's cranked open, it pushes those bulges aside. So it's not captured typically.
Mm.
And unless you have gone into that appointment talking about some symptoms, which some people are asymptomatic, so they're not, then the doctor won't tell you. They don't
Right.
want to, I agree to an extent. I don't want to bring up something that is going to create alarm. But I think if we can capture things so earlier, we can do so much more to prevent it from becoming a big problem. And then the final one I'll wrap up with in this population is pelvic pain. And pelvic pain can be from dryness from that low estrogen state. It can also be from prolapse. It can be from tight muscles. It can be from pain in and around the opening of the vagina, the vulva itself, tailbone pain, pubic joint pain, endometriosis pain. There's many different facets. Like pelvic pain is a really big category.
Mhm.
But a big contributing factor specific to this population would be that low estrogen state where the tissues they're like, a lot of people say it's like sandpaper. It feels like razor blades. Anything touching or being inserted just hurts so much. And that, of course, is then the muscles are going to tense up. And we have the seed that sex hurts. So
Right.
now just the anticipation of sex is that it's going to hurt. And we start to develop pain as well.
Ring a bell, dog will salivate. Yes,
Yep.
absolutely. So we've mentioned a lot of things here, and I'm certain that there are different protocols or suggestions for help with all of these different things. We might in our brain come back to the good old traditional Kegel and think that that's going to be sort of our go-to method of helping heal all of this. I'm certain that's not the answer. So let's break it down a little bit into some of these issues that you've mentioned. You said pelvic pain, prolapse, overactive bladder, anal incontinence, urgency. I mean, that's a lot to go through, but I would love
Yep.
to give our listeners some take home ideas on how they can begin to work with some of these issues if they are experiencing them. So let's start with the pelvic pain since we just ended with that one. What can we do if we are experiencing that pain through sex or pain when anything is inserted? What do we do with that?
Mhm. I always, the number one thing I always say is to see a pelvic floor physical therapist.
Yeah. Mhm.
Most people will go to a family doctor, and I don't want to take away from the role that the allopathic professionals can play within managing any sort of challenges that we have. But I always think first line of defense is best with a pelvic floor PT who can screen much more thoroughly, assess much more thoroughly than the short 7 to 10 minute visit. So it's typically about an hour, and it does a whole health history. It looks externally at tissues, looks at your mechanics in terms of movement, looks at your posture, your breath, but also looks at the tissue, and they can identify if potentially low estrogen or other skin conditions. Something else that mimics the genitourinary syndrome of menopause is called lichen sclerosis, which is an autoimmune condition which can affect the tissues and make it dry and itchy and burning and painful sex and that type of thing. So they can see and screen and suggest you ask your doctor for some vaginal estrogen or use some vaginal moisturizer or a different lubricant, or you have this autoimmune condition, here's how you would treat this. Or is it because you have tight muscles? Is it because you have scar tissue from maybe a previous surgery or from childbirth? And if so, that person, the pelvic floor PT, can help mobilize the scar tissue, can help optimize the response of the muscle so that it's not in that heightened tense state. And also, people who have then developed the fear of insertion, they may use something like dilators to help increase somebody's confidence that you can accommodate something being inserted without pain. So a
Mhm.
lot of it may be biofeedback related. And so I always think that's your number one thing. Figure out why you have that pain, and then the treatment plan can be developed from there. And really, that's going to be my same answer for prolapse symptoms, for incontinence symptoms. I think that the most underused women's health resource we have is pelvic floor PT. And I've been talking about this for 21 years, and still every day, oh, I've never heard of that person or that profession before. I
We
think I
had,
repeat myself all the time,
yeah,
but
I know.
yeah.
We had Corrine Wade. She's a local
Yeah, she's awesome.
Okay. Yeah, she's great. So she was on the podcast last year. And yeah, they get right up in there. They get
Yeah.
right up in there. And literally, they are called, physiotherapists. It's the therapy part of it. And they really do help you determine why the pain is there or whatever it is, right?
Yeah.
Determine and then come up with a protocol that's going to best suit you. So, yeah, that's a great suggestion. You talked about just briefly there vaginal estrogen. So, let's just talk about this for a moment. I've had a few urologists on the podcast. Both have recommended vaginal estrogen. So this is not that systemic menopause hormone therapy. This is just estrogen for
Specific to the vagina. Yeah.
right. So what does that do, and why would that be important? And should every woman be using this?
In my opinion, based on the literature, I think every woman from the start of their menopause or earlier, if symptoms indicate, should be using vaginal estrogen for the rest of their life.
Mhm.
It even like mortality, this sounds dramatic, but UTIs, urinary tract infections, our risk of those goes up after menopause when we are in that low estrogen state, and it becomes recurrent. People then get put on antibiotics, they develop resistance, it can become septic, that can kill people. And
Mhm.
when there was a recent study, it was over 11 million women with recurrent UTIs, and looking at people with and without vaginal estrogen. And the statistics were staggering in terms of mortality and quality of life and reduction of sepsis, like huge, huge numbers. So I look at it like an essential nutrient. I really do. From a quality of life perspective, but really life preserving perspective, it can protect our lives. So I consider it essential. And a lot of people hear the word estrogen and they immediately think cancer. And the Women's Health Initiative was a really big contributor to that conversation by falsely portraying information.
Mhm.
What the accurate data was the arm of that study of women who were using estrogen only. Now, this is not vaginal estrogen, this is systemic estrogen. It was oral conjugated equine estrogen. The population that was only using estrogen, so they didn't have a uterus, they weren't given progestin, they were only using estrogen, had a 23% decreased risk of breast cancer, but that's not what was communicated. They communicated some data from the group that was using PremPro, which was the conjugated equine estrogen, and the progestin, which is not progesterone. It's trying to mimic progesterone. Even there, so there was an increased risk, but even there, it was a small increased risk. And that was blasted like we were all going to die. There was an increased risk of heart attack and stroke. So oral estrogen does increase, again, small, but increases your risk of blood clot and stroke. But the birth control increases the risk of blood clot and stroke more than oral conjugated equine estrogen does. So that's systemic, but vaginal estrogen, it stays and acts locally. So you apply it externally and internally. So clitoris to anus externally, as well as inside into the vagina. It could be a tablet, it could be a cream, it could be a gel, it could be a ring pessary that's inserted and left in for a period of time. So different ways to deliver it. Very low dose. Typically, people will use it twice a week. There are some people who may use it 3 or 4 times a week, but typical is twice a week. And the estrogen itself, very low dose, hardly any, if any, goes systemically. So it's not going to help with hot flashes. It's not going to protect your bones. It's not going to do all the other things that hormone therapy does. It's really acting on the preservation of the tissues locally within the vulva, within the vagina, around the bladder. We have estrogen receptors all over. And when we no longer have the circulating estrogen, those tissues become much thinner. They become drier. It also changes the pH of our vagina. So our vaginas we're usually very acidic. Our vaginas are usually very acidic. They now are less acidic. We are much more prone to infection because of that. Also, without estrogen, as I mentioned, the tissues are thinning. So there can be tissues around the tip of the urethra that retract that will expose the tip of the urethra more, which also will increase the incidence of infection.
Right.
And from a urinary incontinence perspective, all the things we talked about, the urgency, the frequency, the stress incontinence will be increased without estrogen. We will also have burning, itching, irritation. We don't have as much support in the tissues. So prolapse may, again, show up or be more pronounced. So there's a whole thing, genitourinary syndrome of menopause, which is genital symptoms, sexual symptoms, urinary symptoms, all housed under this syndrome, so signs and symptoms. And gold standard is vaginal estrogen. And it's another thing where I also say, don't wait until you have a dry vagina or painful sex or recurrent UTIs. Upwards of 80% of women will experience one or more of the symptoms. It's very clear. So let's intervene early and let's keep the tissues healthy and supple and juicy and moist and able to do all the things that we want to do.
That was going to be my next question because I don't currently experience any issues. I feel like everything is good downstairs. And I said I said that I was going to go get some vaginal estrogen, and I have yet to do that because everything's fine. Everything feels okay. But that is a good point. It's just like anything with the body. You know, we don't have diabetes today. We don't have heart disease today. And so we put off our healthy eating. We put off our high, fiber content. We put off our exercise because today we feel okay.
Mm-hmm.
But that's a good point that this is sort of that thing. I trained an ophthalmologist once, and he had said that if anyone lives long enough, they'll get cataracts like that. Like if you live long enough,
Yeah.
for you, eventually that will develop. So that's a good point that
and with pelvic health, it's so central to so many things in our life. So when it's working fine, we don't think about it. We don't see it. We don't think about it. Everything is fine. But as soon as it starts, something is off. It's now one of the only things we think about because it affects our continence. It affects our sexual response. It affects how we show up in the world and how we move. It affects everything. And so it then becomes one of the only things that we think about. And we start to withdraw from social activity. We don't exercise sometimes at all, or we exercise differently. We move differently. We make planned choices around bathroom. Like our day has to involve thinking about, is there going to be a bathroom there? And is there going to be one there? It's then affecting our personal relationships, intimate relationships, friendships, how we show up for work. Everything is affected. So intervening early, I think this should be taught in schools. When we are teaching kids about the menstrual cycle and sex and bodies, let's teach them about a part of the body called the pelvic floor. And like men have a pelvic floor as well,
Sure. Yeah.
but also highlight when we're talking about the menstrual cycle, your menstrual cycle and your hormones will influence your pelvis and what you may feel in your pelvis and different symptoms and that sex shouldn't be painful. And if you are experiencing these things, once you become sexually active, go see a pelvic floor physical therapist, just like we see a dentist. I remember in grade, I don't know, 4 or 5, something like that, the hygienist came to school and we chewed these pink pills and it highlights the
Black all
plaque
over.
and you're like, oh, and and it was a very powerful motivator for them to tell you to brush and floss and go see the dentist once or twice a year. We all do that. And why are we not getting that same PR for the pelvic floor that is going to, I'm not saying that oral health is not important, but this so greatly affects our quality of life. And if we knew this information earlier and had a kind of a care path of seeing a pelvic floor PT once a year for screening, even if we have no symptoms, I truly think it would change the world.
Yeah, I haven't really thought about it like that, but I totally agree. I think that's very important. Let's talk about incontinence. I saw this viral TikTok the other day. Poor person. She had anal incontinence on the plane. I don't know if you saw that. It was just
No, I
terrible.
didn't.
But they had to reroute the plane, and because on her way to the bathroom, yeah, it was. I would just poor
That
girl.
is mortifying. Oh,
Yeah, totally mortifying. But it obviously can happen. I'm not sure what the problem was with her. But regardless, we can have urinary incontinence, anal incontinence, and that can, like as you said, prevent us from doing jumping jacks, exercising how we used to, or even going out. So, what are some of the things aside from the Kegels? What are some of the things that you're teaching that are no cost that we could possibly do at home in order to strengthen that area?
so anal incontinence is much less prevalent than urinary incontinence, but much more life altering. Now, if that same person had urinated, it may not have had the same, but still, it would still be mortifying. Or you're on an airplane, they probably wouldn't have had to reroute the plane. But anyway, it's
Right.
still impactful. But anal incontinence is very, very, very life altering. Thankfully, it's not as common.
Sure.
The principles of overcoming anal incontinence or urinary incontinence or pelvic organ prolapse really are very similar. There's not one set of exercises only for anal incontinence, one only
Okay.
for urinary incontinence, or one just for prolapse or pelvic pain.
Mhm.
And a lot of the reasons why people have challenges is it doesn't seem logical. So when I tell people that a lot of the reasons why people leak urine or have organ prolapse, have pain, have anal incontinence, it's because of a tight pelvic floor. And they say, but I thought we want a tight pelvic floor. I thought that's what will prevent all this from happening. So people equate tight with strong.
Mhm.
Tight muscles are tight muscles. They have not a lot of blood flow and circulation. They don't have a good range of motion. They're fatigued. They can't develop power very well. They can't respond in the appropriate time. So somebody whose muscles are really, really tight and they feel like they need to have a bowel movement, or all of a sudden they have a very strong urge, the muscles cannot generate enough force to close off the openings. They can't generate that force in time because part of their range of motion has already been used up. They're usually in this tight state, and they need to lengthen the muscles in order to strengthen them, if that makes sense.
Mhm.
You and I work out. We lift weights.
Mhm.
Imagine a bicep curl. We know the range of motion that our arm goes through. If I held my arm in a partial bicep curl all day long, that will eventually ache. And I wouldn't, if I needed to then do something more with my arm, I probably wouldn't be able to do it very well because I'm fatigued. I can't generate as much power. The range of motion has been used up and it hurts. So that same thing is happening in the pelvic floor. And the reasons why somebody has this tightness can be multifaceted. A lot
Mhm.
of it is posture, but a lot of it is also guarding. So that person who was on the airplane is now, I don't know if she's ever going to go on an airplane again, but now she is even more likely to have tension because she's like, I can't let that happen again.
Right.
So unconsciously, her muscles, or maybe even consciously, are going to be gripping, thinking that that's going to help. So tension is a big one. How we address that is we can take if you don't have a tennis ball at home, you can take a small ripe unripe apple and you put it in between your sits bone and your anus. And I usually recommend starting on a softer surface chair first and then eventually progressing to a hard surface just to see how you react. But it's not a big piece of real estate in between the sits
No.
bone and the anus, but it's part of the pelvic floor musculature. And we think of the ball or the apple, whatever we have there, like a strawberry, and we want our muscles to be like chocolate. So we're trying to let tension go in that group of muscles. And you would do that on either side for 20 to 30 seconds ish. Hamstring lengthening is another one. So when our hamstring muscles, one attachment point is up at the on the sits bones in our pelvis, that they show tuberosities. When the hamstring muscles are short and tight, they will pull that pelvis
Okay.
into a posterior tilt. Post prolonged, it's not a bad position to be in and out of a tilt, but prolonged posterior tilted pelvis will typically they will develop more tightness, not only in the hamstrings, but also within the pelvic floor as well. And the glutes are going to become a little bit more inhibited, and the glutes are very important for the pelvic floor. So we want to lengthen the hamstrings. We also want to soften in the belly. A lot
Mm.
of people who are, especially women, they think that they're strengthening their core by keeping their abs engaged all day, or they want them to look a certain way. And constantly engaging the abdomen will create pressure downwards on the pelvic floor. It's tension. It interferes with our breath. And there's a very important relationship of the diaphragm, the breathing diaphragm, and our pelvic floor. So when we take a breath in, if our diaphragm is typically in, I shouldn't say typically, but like after we've exhaled, the diaphragm is in a dome shape and the pelvic floor is contracted and lifted. When we inhale, the diaphragm widens, flattens, draws air into the body. And what we need to have happen below is the belly to expand and the pelvic floor to expand. And if we're chronically gripping in our abs because we think that's strengthening our core,
Mhm.
it inhibits the ability of the diaphragm to move and to draw air into our body. It interrupts the relationship between the diaphragm and the pelvic floor. So we can also then get tightness within the abdomen and into the pelvis. So there's an exercise I do called the belly release, where you just go on your hands and knees like in a cat-cow position,
Mhm.
and you just let your belly hang.
Mhm.
You just let it hang, like just allow it to let go. And that's hard for people to do. You've probably seen, you talked about weird exercises that I do. I take a small Pilates ball, like, and I semi-inflate it so it's sort of squishy. And you can sit on a chair and just roll around. You can kneel over it. You can put that on your belly and like if you're lying down prone and put the ball underneath your rib cage or onto your belly and do some rolling around there. It can be uncomfortable for some people, but it can really be helpful to help us soften and to relax and to release and let the body feel like it's okay to be soft. We are always like, we've got to be strong. We've got it this. And fitness has contributed to, like, for a long time, fitness was just like harder is better and harder. Everything was something harder every single day. And there's a little bit of a softening that's happening now. But a big thing is just releasing tension in and around the pelvic floor. So directly in the pelvic floor, but also the surrounding musculature is really, really important.
Yes, I've heard that athletes like people who dance, ballerinas, even hockey players can get a lot of that tightening since they're in that positioning so much, core engaged, shoulders back, right? Everything is tight. And I mean, I used to do that too. You'd wash the dishes and you'd think, suck it in, keep it tight, keep it taut.
Yeah.
But that's really good advice to just relax that part, especially when you're doing certain activities,
Yeah.
sitting, even, like sometimes I'll think, oh, posture, and I'll engage the core as opposed to just allow that some opportunities. Because I think we're doing it enough when we are working out, right?
Yeah.
That's probably an adequate amount of time to be engaging those muscles. So other times should be spent.
Yeah. And I want to highlight, you brought up Kegels, and
Mhm.
so Dr. Arnold Kegel was witnessing his female patients post childbirth experiencing challenges with the pelvic floor. They couldn't feel or sense it as much. He used something called a perineometer, which was a biofeedback device to help them learn how to contract and relax. And that's where the Kegel exercise was developed. We have loads of evidence that Kegels are beneficial. They work when they're done correctly and consistently. But we also have loads of evidence to show that the majority of women do them incorrectly because they've never been taught. It's this elusive exercise that we all know we're supposed to do, but we don't do correctly. because nobody's taught us how to do it. So it's not our fault. Then we think they don't work because we don't notice any change or we notice things get worse. So a Kegel is a voluntary activation, like contract, lift, and let go of the pelvic floor. But most people interpret a Kegel as a squeeze only. And most people are squeezing their inner thighs or squeezing their glutes. Some people even hold their breath and bear down, thinking they're doing a Kegel exercise. And when we think about, things we can be doing at home, we can do Kegels. However, you just said when we're working out, we're activating certain muscles. And my whole buff muff philosophy is we need to take the pelvic floor into our movement. We need to train it dynamically. Doing 3 sets of 10-second hold Kegels correctly every day is going to be better than nothing. However, most of the symptoms, the leaking, the pain, the pressure, the heaviness, that happens when we are upright against gravity, when we stand up from a chair, when we lift a weight at the gym, when we carry groceries into the house. If we're not training the pelvic floor in upright movement, in dynamic movement with load, we're missing out a huge opportunity for capacity and resilience within that really important group of muscles. It's our foundation. It's the foundation of the core. So let's bring it into core exercise. And we can really turn a lot of other exercises into a core exercise if we actually bring the pelvic floor into our movement.
Exercise is one component for sure, but what other daily habits, maybe thinking posture, hydration, movement, are the most critical for long-term pelvic health, especially in menopause?
Yeah, those top three. So hydration, that's going to be always kind of like number one, because many people who are leaking, who are afraid of having urges, they stop drinking because they think, well, if I don't drink, then I won't have that urge, or I won't leak, there won't be anything there. And then they become dehydrated and the urine becomes more concentrated, which will irritate the bladder, which then the bladder will want to get it out more frequently, more strongly, more urgently. So hydration is key. 2 to 3 liters of water a day is what I recommend. So the bare minimum is half your body weight in ounces per day. But if you are active, it's going to increase. So generally, most people are going to fit in that 2 to 3 liter zone somewhere throughout the day. So don't front load. Don't like wait until the end of the day. Just try to drink consistently throughout the day. And that's also then going to help with number two, which is literally number two, constipation, your poop. If you are dehydrated, if you are not drinking water, you are not going to poop well. And if you are not getting the SHIT out, literally, then that's not from a toxin, like it's waste. We need it out of the body. And if we are not getting it out of the body, our health will suffer. But also when the poop is stuck and not coming out, it also increases urinary urgency and frequency, and you feel uncomfortable, but it also increases those urinary symptoms as well. And when we are trying to get it out, the straining and the bearing down is damaging to the pelvic floor and can contribute to or exacerbate, especially pelvic organ prolapse. So if somebody is dehydrated and constipated, I could give them all of the magic exercises, but it's really, I don't want to say it's not going to do anything, but it's not going to help as much as we want it to. So those two things have to be addressed. And what can also help with constipation and pelvic floor function is posture and how we hold ourselves through the day. And I mentioned the relationship between the diaphragm and the pelvic floor, and that happens when we have this optimal alignment of the rib cage over the pelvis. That doesn't mean we have to have rib cage over pelvis in everything we do and never deviate from there. And it doesn't mean that we can't ever be in a posterior tilt and slouch. We absolutely can, but that shouldn't be our default position for the majority of our day. We should have movement diversity, like we should have food diversity for our gut. And we should be incorporating, a lot of people are using the term movement snacks now, throughout our day to take us out of maybe a non-optimal position. When we're sitting, ideally, if we can sit on our sit bones, on our vulva with a gentle curve in our low back, that is going to be more favorable than sitting in a posterior tilt where we are sitting more on our tailbone. Again, doesn't mean we can't hang out there for a couple minutes, but don't spend your entire day there. So posture is huge. Hydration is huge. Eliminating constipation is huge. And then it's going to be the other tissue support things. So vaginal estrogen, vaginal moisturizer, lubricant with sexual activity with or without a partner. And then doing some sort of exercise through your day, bringing the pelvic floor into it, more so with like resistance training, not so much like I don't want you out on a walk doing, Kegels while you're walking or running or swimming, or cardiovascular is not necessarily where you
Yeah.
do your active voluntary pelvic floor work. It's more with resistance training, bridges, yoga, Pilates, that type of thing.
Yeah. Yeah, we do, throughout my workouts there, we'll go up into glute bridge and come down and up and down, right? And so that's a great opportunity to practice picking up. I think Corrine Wade said picking up the blueberry,
Yep.
pulling it up and then
Yep.
down. So that's,
And
yeah,
when you're
so
initially starting, like for somebody who is first getting into this, there's sort of if somebody comes with active symptoms, we want to have this retraining phase where we want to retrain the reaction time. We want to retrain the ability to generate force, make sure we have the length to develop, like to move through the range of motion to develop the strength. And we want to retrain the anticipatory element of the pelvic floor. So in studies, we know the pelvic floor contracts milliseconds before movement. So milliseconds before we move an arm, milliseconds before we lift something up, before we cough, that's what should happen. When that anticipatory element is disrupted for whatever reason, we need to retrain that. So when we initially start a bridge example, we would be on our back with our knees bent. We're going to inhale. I always use the image of blossom your vulva. So inhale and expand. And then exhale, purse your lips and blow, pick up your blueberries, then press up into the bridge. And then inhale and blossom your vulva as you come back down. So for a period of time, you're going to exhale to engage the pelvic floor, pick up the blueberries just before you do the movement. And that helps retrain that
mhm,
reaction time.
mhm,
And then eventually we pick up the blueberries as we lift up into the bridge. And then eventually ultimately we should be able to just do the bridge without having to think about the pelvic floor.
mhm.
However, we still need an element of pelvic floor muscle training, just like we need resistance training for all the other muscle groups in our body. And we do know from research that a whole body resistance routine is actually not enough to completely strengthen the pelvic floor most optimally. So they need their own set of exercises. So let's bring that into not our entire workout, but at least a portion of our workout for certain exercises. Let's bring the pelvic floor in so it's getting its workout as well.
I love that. You have something called the Buff Muff method. Tell us about that. It's a course that you offer.
Yeah, it's a membership community, I would say. It's similar to yourself. I have routines based on certain pelvic floor symptoms, based on different techniques that can help optimize the reaction time of the pelvic floor, the strength, the length of the pelvic floor, also helping with prolapse, so very specific symptoms, but also showing people what's possible even though you may have pelvic floor dysfunction. So many people are told you can't lift, you can't twist, you can't crunch, you can't jump. And what are most people told now that's being screamed across the internet? You have to jump, you have to lift heavy,
Yeah.
right? And so now they're thinking, well, I've been told that I can't do that because of my pelvic floor. Or maybe they've just
Right.
said, that feels bad in my body when I do that. It bothers my pelvic floor when I do that. So they stop. We have research that shows 46% of women stop exercising because of their pelvic floor.
Mm.
And when we think about the risks to our health from diabetes, osteoporosis, heart health, especially post-menopause, we have to
Yeah.
look at the pelvic floor as being a major contributor to that. So let's optimize the pelvic floor and apply the same principles as we do to any other muscle group, progressive overload, principle of specificity, right? And so my program is based on retraining. So people come in, they have a basic, like, what is the pelvic floor? How does it work? What is incontinence? What is prolapse? They learn a little bit first. Then we go into some basic fundamental exercises, the core breath being one of them. People can find this for free on my YouTube channel, the core breath video. And then we start to layer it into movement. And from there, then we go into resistance training, HIIT training, yoga. I've got some dance stuff. I'm not doing it. I have a person who helps do some dance, but all sorts of different types of movement where we are incorporating awareness of our alignment, our posture, our breath, activation of the pelvic floor. And people come in and go from having symptoms and not exercising to exercising without symptoms. Some people have canceled surgeries, like they've been told they need a hysterectomy or they need a prolapse repair, and they come in and finally understand why this has happened. And now I know what to do to reverse it. I didn't realize constipation was so bad for my pelvic floor. I
Yeah.
didn't realize the way that I held my posture through the day was so bad. And now with these subtle changes, it can help. So that's really, it's a membership community where people can come in and go through different 28-day challenges and also feel like they're not alone in this. It's not easy to talk about. There's a shame and a taboo that I'm trying really hard to remove. But when people come in and they see on our group calls that they're not alone, and they also learn from other people, and they witness that this is a there's a lot of people dealing with this. And then they also hear the success stories and the people who've made progress. And that's motivating and empowering. And it gives people hope rather than, especially us living in Canada, we know the wait list it takes to see a specialist. So during that time, they're just sitting, waiting, not afraid to do anything because they think it's going to make things worse. And then they get to that specialist and now they're told they need surgery. Well, do they have they seen a pelvic floor PT? Have they done all the lifestyle interventions? Can we remove that as I don't want to take it, it's an option and it can be a great option for many people. But even if that is an option, we have to train for it. We have to train for that surgery. So all of that you kind of learn within the Buff Muff method. And yeah, I love it. I love supporting women there.
I think that what you just said at the end there is very true, that there are a lot of lifestyle factors that we can tweak and do. I think we talk about them lots at Move Daily as well. And I feel like a lot of times women just don't progress through those sort of boring, monotonous little exercises or tasks or daily dripping water on the stone. It's just some of this stuff is a little boring. But if you continue with it, and if it's, something that's part of your daily routine or weekly routine, you're going to see a difference, right?
Yep.
I think we just want the quick fix now. We don't want to feel like we're feeling today. We just want it to be different tomorrow.
Yep.
But these things take time. And again, showing up for yourself on a regular basis, I think is really important.
Yeah.
Kim,
Yep.
where can people follow you and find you on social media? Tell us your podcast as well.
Thank you. My website is vaginacoach.com. You can also go to buffmuff.com and learn specifically about that community. And my social handles are all at Vagina Coach. If you go to Google and put Vagina Coach, you'll find me somewhere. And my podcast name is called Between Two Lips.
Yes, that is funny. I like that one. Awesome. Well, thank you so much for being my guest today. I definitely am going to go. I had this in my brain to get the vaginal estrogen. I've put it off. So I'm speaking to myself, folks, when I say do all the little things.
Yep.
I'm going to be doing
and
that.
see Corrine once a year, even if you have no symptoms. That's another thing you can do.
Yes. I have done we've done little tutorials at her house where
Awesome.
I was on the floor. She had me she was doing things to me, like good things, but she's just right in there. She makes me laugh a lot. I'm constantly embarrassed laughing with that woman. All right. Thank you again for being my guest. And now to all of you, go move daily in your fitness, wellness, nutrition, and pelvic floor health. And we'll see you all in the next Move Daily Talks.